Hello, everyone. Thank you for joining us today. My name is Melissa Miller. I'm a medical officer in the Division of Healthcare-Associated Infections, Center for Quality Improvement and Patient Safety at the Agency for Healthcare Research and Quality. And I'm the project officer for the AHRQ Safety Program for Improving Antibiotic Use. The call today is to talk to you about participation in an acute care hospital cohort starting in December 2017. Through this project, we aim to measurably increase antibiotic stewardship activities in acute care hospitals, long-term care facilities, and ambulatory care facilities nationwide. We're excited about this program and have a lot of confidence in our team of experts in both the comprehensive unit-based safety program and antibiotic stewardship. And very excited that you guys have joined us as well today. So I will delay no further, and I will hand it over to our very capable project team. Dr. Pranita Tamma will start things off.
Hi, good afternoon and good morning to some of you. My name is Pranita Tamma. I'm a pediatric infectious diseases physician at Johns Hopkins Hospital, and I direct our antibiotic stewardship program. On this contact information for the AHRQ safety program for improving antibiotic use. And if you have any questions or need to reach me after this WebEx, please feel free to use this information. The AHRQ safety program for improving antibiotic use is a collaborative intervention funded and guided by the Agency for Healthcare Research and Quality, and it's being led by Johns Hopkins Medicine and AHRQ at the University of Chicago. And the overarching goal of the collaborative is to improve antibiotic prescribing practices and assist facilities with implementing effective antibiotic stewardship programs. And as a reminder, the goals of antibiotic stewardship are to ensure that all patients requiring antibiotics receive the right dose, at the right dose and for the right duration. And antibiotic stewardship has been shown to reduce unnecessary antibiotic use, adverse events, and the emergence of antibiotic resistance. The safety program is unique because it addresses both technical aspects of prescribing, such as best practices antibiotic prescribing for common infectious disease syndromes, as well as adaptive aspects of prescribing, such as safety culture, behavior change, teamwork, and communication. And while there are gaps in prescriber knowledge about antibiotic prescribing, behavioral issues such as fear of underprescribing and not wanting to offend other prescribers are also important drivers of unnecessary antibiotic use. I'll just stop for a second because I saw a question asking if the slides will be available, and after the call we'll make sure to send slides to all participants. The safety program lasts for 1 year with a 3-month baseline period starting in December 2017 and 9-month intervention period starting in March 2018. And the program is free for all participating hospitals. Entire hospitals are invited to participate, but individual units within hospitals can also still participate. We believe that there are several benefits to participating. Participants will have access to antibiotic stewardship experts for coaching and troubleshooting, as well as interactive webinars, which we held 1 to 2 times per month, and cover both technical and behavioral approaches to improving antibiotic prescribing. And these webinars last from approximately 30 to 60 minutes in length, and this will be recorded and available on the project website for anybody who misses the webinar or needs a refresher. And their slides are also available on the website and can be downloaded along with a facilitator guide so that they can be adapted for local presentations as needed. Participants will have access to a variety of educational materials, including fast fact sheets and e-learning modules that summarize existing knowledge and recommendations related to antibiotic prescribing. Fast fact sheets that will be developed can be used for education on rounds or modified to facilitate development of local treatment guidelines for common infectious disease conditions. Other tools to assist with local antibiotic improvement interventions include an antibiotic timeout tool, a antibiotic review form, which I'll review shortly, an identifying antibiotic defects tool, and a Learning from Antibiotic Defects tool. And we developed educational pamphlets for patients and families, as well as commitment posters indicating that the facility is dedicated to safe antibiotic prescribing practices. And finally, materials to assist with compliance with the Joint Commission's stewardship standard, such as sample policies and healthcare worker educational materials, will be available to participants. The expected outcomes of participation include improving safety culture around antibiotic prescribing in hospitals, enhanced teamwork and communication among healthcare workers and between healthcare workers and patients and families, reduction in unnecessary antibiotic use, improved antibiotic decision-making by frontline staff, reduced Clostridium difficile infection rates, and improved compliance with the Joint Commission antimicrobial stewardship standard. The next slides will provide some additional information about the approach and content of the intervention. The overarching approach to antibiotic prescribing that will be used in the AHRQ safety program is called the 4 moments of antibiotic decision-making. Teams are asked to adopt this approach when making antibiotic prescribing decisions. The 4 moments are: moment 1, does my patient have an infection that requires antibiotics? Moment 2, have I ordered appropriate cultures before starting antibiotics, and what empiric therapy should I initiate? Moment 3, a day or more has passed, can I stop antibiotics? Can arrow therapy or change from intravenous to oral therapy? And moment 4, what duration of antibiotic therapy is needed for my patient's diagnosis? This slide lists topics covered in the webinars that address adaptive issues. Of note, with the exception of the title in green, these webinars are directed to both local stewardship leaders as well as primary teams. Thus, all participants are encouraged to call into the webinars. And the specific topics that will be included are behavioral change theory for antibiotic stewardship leaders, improving antibiotic use as a patient safety issue, improving communication and teamwork around antibiotic prescribing, identifying defects to improve antibiotic use, improving antibiotic use from learning from the defects that have been identified, and sustaining antibiotic stewardship efforts. This lists topics covered in the webinars that address technical issues. Again, with the exception of the title in green, these webinars are directed to both local stewardship leaders as well as primary teams, which really consists of frontline staff. And specific topics include antibiotic stewardship program development, stewards of asymptomatic bacteria and urinary tract infections, stewards of community-acquired lower respiratory tract conditions. So this includes community-acquired pneumonia, aspiration pneumonitis, chronic obstructive pulmonary disease exacerbations, steward of healthcare-associated and ventilator-associated pneumonia, stewardship of skin and soft tissue infections, stewardship of intra-abdominal infections, and stewardship of Clostridium difficile infections. The program complements the Center for Medicare and Medicaid's partnership for Patients Hospital Improvement Innovation Network initiative. One of the goals of the HIN initiative is to reduce Clostridium difficile rates through adoption of antibiotic stewardship. And as you see from the subjects we just discussed, the safety program is designed to help improve antibiotic use, and in addition, there is a specific emphasis on approaches to reduce Clostridium difficile laboratory ID events, as well as Clostridium difficile infections. 5 pieces of data that are requested to participate in the project. First, monthly data on days of antibiotic therapy per 1,000 days present, stratified by antibiotic type and unit. We decided to use the approach outlined in CDC's NHSN antibiotic use and resistance metric that can be found at the website shown. And we realized for some sites may have difficulty obtaining electronic data in this format, and we encourage you to contact our project team to discuss alternative options. And quarterly Clostridium difficile lab ID events per 10,000 patient days stratified by unit. These should be available via your infection prevention program as they're required to be reported to the CDC. Third, teams are requested to complete 10 antibiotic review forms per month to identify and track improvement in antibiotic prescribing according to the 4 moments of antibiotic stewardship. These forms are completed by the stewardship team and frontline teams collaboratively. A completion guide is provided to facilitate filling out the form, which we estimate to take approximately 5 minutes. And the slide shows a picture of this form. For the beginning and the end of the project, sites will complete a 1-page form about stewardship practices and activities to assess baseline status and status at the end of the intervention. At the beginning and end of the project, sites complete the hospital survey on patient safety to assess if there have been changes in safety culture during the intervention. Many hospitals are already requesting employees complete these surveys on an annual basis. So this slide summarizes the activity required of participating hospitals. We ask that you identify an antibiotic stewardship team. Now, we do not have an antibiotic stewardship team already defined at your institution. You can still participate, but we do request that you identify leads who would like to be trained to assume this role, and during the course of the AHRQ safety program, we will train these individuals into being antibiotic stewardship leaders. We ask that you identify and engage frontline staff on participating units or clinical services that will participate in the AHRQ safety program. We ask that you participate in monthly webinars with experts. As mentioned, we realize that busy clinicians may not always be able to make the webinars. So for the staff that are not able to make a webinar or want to listen again to what they learned, these webinars will be available on the project website. Between webinars, we ask that you identify antibiotic-related defects and identify solutions and incorporate some of the tools we teach you about into practice as you see fit. Finally, we ask that you submit the requested data to the project website. This slide shows the timeline for participation. As I mentioned before, you will receive copies of these slides. To learn more and enroll in this program, please visit our website listed here, and then you can complete the online application. If any questions you have through the process, please feel free to email us, and we'll respond to you promptly. I thank you all for your attention, and I'll open up the lines to see if there are any questions that we can help with. Thank you all again.
Questions, press *1. Our question is from Charlotte Carr.
Hi, you know if the slide deck would be made available. You may have mentioned that, but I didn't. I might have missed it.
Yeah, thank you for the question. Yes, we will make these slides available.
Thank you.
And yeah, definitely feel free to disseminate within your institution or others you think might be interested. And if there is anything missing after you review the slides, please let us know.
And it's from Amy Taylor.
Hello, I was wondering, how is the ASC involvement with this? I know you've talked about hospitals a lot.
The ASP involvement, is that what you said, sorry?
ASC, ambulatory care.
Oh, sorry, ambulatory care. So yeah, thank you for the question. So currently we're undergoing a pilot study that includes several health systems where we're piloting the material that's being developed for care, long-term care, and ambulatory care practices. Beginning in December 2017 for a 1-year period, we'll have the large-scale acute care rollout. The following year, December 2018, over 12 months, we'll do the same for long-term cares. And the following year, beginning December 2019, we would do the same for ambulatory care practices. So currently, beginning in December 2017, the focus would be on acute care facilities.
Thank you.
Thanks.
The next one is from Jen Lau.
Hey, Katie.
Yeah, thank you.
Okay, great. I'm just wondering if you're targeting specific types of hospitals or any and all that would be interested. Like, would you be looking at hospitals that are having difficulty meeting all core elements as defined by the CDC, or doesn't really matter to you?
That's a great question. It doesn't matter to us. We're going to have material tailored for various levels. As I mentioned before, what we really want is if you don't have a stewardship program, that you at least identify a physician and or pharmacist who would be interested in receiving training for this role. I think it's personally helpful to have a mix of hospitals with different skill sets because we are hoping that during the webinar there will be didactic information, so sort of scheduled webinars, scheduled information that will be delivered, but we also want there to be coaching and questions and sharing ideas. And I think having people from different levels of experience would make that more interesting. So to answer your question, any acute care facility with whatever experience they have related to stewardship are welcome to join.
Thank you so much.
Material we're planning on preparing as I outlined, but we definitely welcome feedback if there's other material that would be helpful for us to make available. We're happy to have additional coaching calls or make additional information available on the project website during the course of the year if we realize that there's some crucial information that might be missing that could help some participants.
The next is from Brian Hughes.
Yes, thanks.
Okay, great. I'm wondering if there will be any kind of support for creating a DOT report for our data. We have created a duration of therapy report, but it doesn't meet the criteria that the AUR uses, NHSN uses, and which is, obviously is much more complex. And so we're exploring, or just starting to explore whether we were party or how we're going to go about actually getting the data for NHSN.
Yeah, thank you. That's a great question. I think as you're alluding to, a lot of us have had difficulty figuring out how to get data in the format that's being requested by AUR, and many of us are still not submitting. In fact, that's true for most facilities. We certainly information, like I mentioned, it's for those of you where this is sort of causing you anxiety, this would not be a reason to preclude participation. We can definitely talk about alternate options, but it would obviously be helpful to have some antibiotic use to measure. But to answer your question, I think that we can certainly, either through a call or through a webinar or some other mechanism, come up with some sort of primer for those institutions trying to figure out how to navigate the system, because I would imagine that this is going to be an issue for a lot of places that are interested in participating. We've worked closely in the Johns Hopkins Health System with an IT person who's really been spending a lot of time in this area, so I'm sure some helpful advice that we'd be able to share through him.
Okay, thanks.
Thanks.
Next question is from Buddy Newton.
Hey?
Yes.
Great. What about rapid diagnostics? You've got a lot of things outlined as far as specific syndrome calls, basically. And what about incorporating rapid diagnostics into that, or having a subgroup talking about that?
Yeah, you mean rapid diagnostics like new molecular tests, or sort of, are thinking more procalcitonin or C-reactive protein, or are you just sort of talking about in general?
In general, specifically, we do a lot of procalcitonin work here. Yeah. Then we're also getting to purchase the Cepheid machine so we can get, de-escalating vancomycin use when nasal swabs are negative. Things like that.
Yeah, that's great question. What we're trying to do, rather than have a separate webinar on rapid diagnostics, because we've thought about that before. Obviously, as you know, there's been this explosion, and there's so many available. So what we're trying to do is, within each syndrome, have some time devoted towards rapid diagnostics and how they may or may not be helpful. I think that, your question about de-escalating from vancomycin, for example, is an important one. And, just like the Cepheid, the rapid diagnostic, there are several other tests just like that. So we certainly can make mention of some of the ones we're familiar with. Others, the webinars might have other diagnostics that have a similar function but might work a little differently. So I think what I should say is that we definitely allude towards them and talk about what their role could be in helping with modifying therapy. But we would welcome on the webinars for people to talk about their specific experience with individual assays they may have introduced in their facility.
The next is from Ken Gagnon.
I have 2 questions. Can you hear me okay?
Yes.
The first is the limit on the number of hospitals that you can take into this program?
So we're looking to recruit somewhere in the range of 250 to 500 facilities. But at this point, we really welcome enthusiastic participants. So, if you're interested, we definitely encourage you to visit the project website and to start that process. But we do have a large number of facilities we're looking to involve.
And the second question is, you had a slide that talked about consultation, 30 to 60-minute consultations. Can you go into a little bit more specifically about what you mean by that?
So I'm sorry if I use the word consultation. I probably meant webinars. So what we would be anticipating beginning in December 2017, for the first few months there might be 2 webinars per month, and after that it'll probably be a single webinar a month. These generally in the pilot period have been lasting between 30 to 60 minutes, and it involves some pre-developed content that we'd be sharing, as well as making sure we have enough time for questions and answers. As I mentioned before, we're happy to have more webinars. There are other topics that we find that are important for us to address. And because there will be a large number of participants, we plan on having the same webinar repeat a few times during the month at different times to take into account different time zones, and everyone's schedule is a little different. So to give people multiple opportunities to be able to participate on the live webinars. And the material will, of course, also be recorded and posted on the project website.
I was just curious if you had any consultative support for small rural hospitals that didn't have an infectious disease support session.
And I will say that Sarah Cosgrove and myself, who are leading the project from the Johns Hopkins Medicine side, we both have been involved in stewardship for some time and have a lot of people who've been in the field working in all sorts of environments. So we always welcome questions to the project website. We can get back to you. So if you want sort of a more individualized question related to stewardship in rural settings, or we'd be happy to put you in touch with others we know who are working in similar areas and who've been successful. So we'll definitely be more than happy to serve that role.
Sounds great. Thank you.
Amanda Dawson.
Hello, I was just wondering if you were going to be cohorting different units and different acute care hospital types. So, for example, a long-term acute care hospital, if you had multiple participants, we'd be cohorting them separately. Thank you.
Yeah, it's a really good question. We've been toying with all sorts of ways of cohorting groups. At this point, I think while we're still sort of in the recruitment phase we're just slowly starting to see, we're getting a lot of interest in the program, which is great, but we don't have a great sense of and how many, for example, long-term acute care hospitals there will be, how many ICUs, et cetera. So for now, the plan is not to do that. That may change depending on the types of participants. And as I mentioned, if there are specific needs for a subgroup of participants that are different from the larger group, we can always come up with ways to modify our approach so that everyone feels that they're getting the most out of this program.
No further questions on the phone.
I'll just check in case anyone has emailed any other questions. Somebody is asking the question, will CME be provided for any of the webinars? That's a great question. We're actually actively working on that right now. So our hope is that it will be provided, but over the next several months, we'll have more information on that. Thank you for that question. Someone asking, for those getting days of therapy from a third party, these data often lag a quarter behind, would hinder the ability to participate in this project. Also a very good question. We have the same issue where our data does lag behind. That definitely would not hinder participation. And I think someone asked me, someone posted the question, what in the data abstraction form for the monthly cases? So yeah, this is a great question. So I know the image I showed was very small. We developed a form, we call it the Team Antibiotic Review Form. It's a front and back page form. And basically what we're asking is that the stewardship team, again, either the existing team or the people who are sort of going to want to assume this role and be trained during the course of this program, would meet with a participating unit. So for example, if a MICU is participating, we ask the stewardship team to sit down with members of the MICU and review 10 patients receiving antibiotics at any point during the month. So it could be a few at a time, 10 at a time, and quickly run through the form, which is sort of designed after the 4 moments of antibiotic prescribing, get a chance to see if there was room for improvement. So for example, if a patient started on vancomycin and piperacillin tazobactam and colors are back and they know that it's okay to de-escalate, it would be an opportunity as a group to review the patient and say, you know what, we probably didn't need the vancomycin in the first place because there wasn't any concern for MRSA. Now we have some culture data back. We can definitely stop the vancomycin. Maybe we can change the pip-tazo to something narrower or even something oral, et cetera. So it's really meant more for a way to discuss individual patients specific to your unit, using both the expertise of your stewardship team as well as frontline staff. So you come together as a group to sort of understand how to incorporate antibiotic decision-making into daily practice. The form does not request any PHI. So as the project, we definitely don't want PHI or any specific patient identifiers. Our goal is really more to make sure that people are using this process in their thinking. And to be honest, part of the reason we're asking for this form is to encourage people to find the time, because obviously everyone's very busy, but to find the time to sit as a group to discuss cases. Because we really think that that would bring back a lot of the learning that's taught on these webinars. Sorry, it's a very long-winded answer to that question. I think the rest of the questions that I'm seeing posted. Oh, I'm sorry, there's one more question here. Are we able to confer rights to the project within CC's NHSN so you can access the AUR data directly? That's another great question and something we discussed recently that we're going to try to do. So for those of you that do submit to the AUR, we would explore this as a possibility. I believe I answered all the questions that were posted online. Does anybody have additional questions or anything they thought of in the last couple of minutes?
Once again, *1 for any questions. We do have a few more on the phone. We have Jay Kim.
Hi. As you're talking about the the antibiotic form, you were mentioning just the unit participation. So is this just including just one unit in the hospital, or multiple units in the hospital could participate?
Yeah, thank you for the question. So we're encouraging as many units as want to in a hospital participate. It doesn't even have to be units. It could be clinical service. So, for example, if you have a hospitalist group that rounds on multiple floors in a hospital, or a GI consult service, whatever people view as their units or their teams are welcome to participate. And there's no limit. We encourage as many as would like within an institution. We realize for some places it may not be feasible for more than one unit or clinical service, but others, even in the pilot, have requested that multiple units participate, and that's great also.
Question is from Mary Gumto.
Thank you for the opportunity to share this today and ask my questions. I have a couple. How long has the pilot been in place, and does the pilot include acute, ambulatory, and long-term care facilities?
Yeah, so the pilot actually started on April 1st, 2017, and it's actually going to continue for a year. So it'll actually continue a little beyond when the acute care rollout begins, which again is December 2017. In the pilot period, we have participants from Carolinas Healthcare, Geisinger Healthcare, and the Johns Hopkins Health Systems, and there are a variety of acute care, long-term care, and ambulatory care sites. In total, there's approximately 30 sites participating in the pilot.
Nice pilot and a nice cross-sampling. And then, this is kind of twofold. Everything is submitted via a report, so there's a specific format. It isn't a file-based upload or anything like that. We support all data via a report.
Yeah, thank you for the question. Priscilla, are you able to answer that question better than me? I mean, I'm sure you could answer better than me. But I'm not very good with IT, and NORC at the University of Chicago have been the ones managing the website.
Yep, I'm happy to answer the question. So we have the forms available online. So Pranita mentioned the antibiotic review form. So those are accessible online, and you can complete them and submit information online. So we have that capability, but we've also established a capability for you to upload, some of the clinical measures that Pranita went through. So we're happy to work with your facility to, figure out what would be the best way or the most feasible way for you to give us, the information that we're looking for.
Well, based on that, I was wondering how demographic information, the birth, the event, ICD-10, just NOCs, how I was considering those different possibilities, but maybe I'm drilled too far.
No problem.
Okay.
A couple things. One, I just want to sort of also just stress that information that we are looking for, is going to be de-identified, okay? So that's just one thing in terms of just thinking about the kinds of information that you'll be submitting with us. In terms of clinical measures, we've already developed, quite detailed information, like for code books and the like, on exactly what we're looking for. And we can certainly meet with you offline from this call, share with you some more specificity if that's what you're looking for.
And to that end, how much, so we would need IT support perhaps, but how much time do you think this project takes? Per week, per month?
Yeah, that's a question. I think some absolutes that we're hoping for. We're hoping that on a monthly basis, sometimes for the first probably about 2 months, it would be twice a month. We're asking for up to an hour on a webinar to discuss either adaptive or technical information related to antibiotic stewardship. Between these calls, what we're hoping is that people will take the information they learned, will use some tools that we think are helpful sort of to improve the behavior and teamwork around antibiotic prescribing. So we're hoping that between those people will take which tools that they think could be helpful for them. We realize there's not an easy one-size-fits-all approach, and come back to their group. So, for example, if you're a stewardship leader, you might be on the call, and a couple of people from your MICU might be on the call, but there's several who may not be. So we're hoping that between calls, maybe once a month or twice a month, depending on what's feasible, you would sit down with other members from your unit and review some of the material that was learned on the call, figure out if some of the tools are useful, how would you incorporate it into your daily or weekly activity, and maybe take some of the fast fact sheets we develop and say, you know what, this is a fast fact sheet on community-acquired pneumonia. This would be great for us to convert into a local guideline, and you sort of replace some of the drugs with drugs in your hospital formulary, et cetera. So that's sort of day-to-day or week-to-week practice that you would be taking back to your units. It's not something we would be monitoring or having you report to us, but we're hoping that, you know, these webinars will be stimulating enough that you would want to take back what you learn and bring it to your unit. So again, the sort of absolutes asking for are identifying stewardship leaders, you know, figuring out your unit or units or clinical services that are interested in participating, engaging frontline staff to participate. So we would give individuals a username password for the project website, so they could either call into the webinars, which is great, and if they can't, they can still access the material. Ask you participate in these monthly webinars, and then between webinars, you would take what you're learning from the webinars and implement it. And then once again, for the data we're requesting, you know, the antibiotic use data that we're looking for those of you who have stewardship programs, and for you that you know, are concerned about Joint Commission accreditation, which I'm assuming is probably all of us, or most of us, you know, figuring out how we can access our antibiotic use data is something that probably is on all of our minds already. You know, some places are just much more sophisticated than others. We've only recently been able to map out the data that we're hoping for to follow the AUR recommendations. So, you know, we realize for some sites that getting their use data will be a work in progress, but we'll work with you figure out to give you tips on what worked for us, and then I'm sure there's others with different EMRs on project, and we hope that we can all learn from each other. The other data we're asking for is the C. diff rates, which again is something you're probably reporting already at HSN. The 10 antibiotic review forms per month, which the way I envision it would be between the webinars when you meet with your units to figure out how you can implement some of the information you learned on the webinars. That would be an ideal time to fill out these antibiotic review forms. And then finally, we're asking for the staff safety assessment, which many facilities already ask their staff to complete, and then a one-page structural assessment basically outlines what existing infrastructure you have in your institution with regards to stewardship and other safety interventions that have occurred.
I would say thank you.
Yeah, thank you.
I think this is wonderful and just wonderful sounding program, and I would think that we could take one unit and pilot it at our hospital. I was kind of thinking a larger group, but I think one would be manageable.
Great. We're very enthusiastic about this. We think that until now, a lot of interventions targeting stewardship focus on the technical change and really sort of ignore the adaptive behavioral issues that we think are so critical to changing how people think about antibiotics. So, yeah, very excited to work with people who are interested in this. And we also want to make sure that we think about how can we get nursing involved and other healthcare providers who may not have traditionally been thought of in that stewardship role. So we're very excited, and I'm sure for all of us we'll be learning a lot during the course of the year.
Well, the emphasis alone on that culture first. You know, obtain culture so you know what you're treating. So thank you very much. I appreciate it.
Thank you. There was just a couple of questions posted. Somebody had said, quote, I'm pretty much our stewardship team. Can it be just one person on the stewardship team? And absolutely. We understand for some places there may be a single pharmacist, single physician. They may or may not be trained in infectious diseases. That's perfectly fine. Like I said, there's no size limitation for participation. Somebody asked if critical access hospitals can participate, and definitely. Those were the questions that have come through the chat feed since I last checked. Other questions?
I have further questions.
Well, thank you so much. Like I said, we will make sure these slides are available to everybody who participated on the call. Please feel free to reach out to us for any questions. If you're interested in participating and something about this seems like it would make it difficult for you, definitely reach out to us so we can sort of discuss options. Well, thank you all again. Priscilla.